Thank you very much. So I'm actually presenting results of a study that we've just finished, and we're actually about to submit for publication. So you're one of the first to hear the results. It's called the KADS study, which stands for the Ketamine for Adult Depression study. And it's a 4-week midazolam-controlled RCT giving subcutaneous ketamine, racemic ketamine, for treatment-resistant depression. Now, we were very interested to see this meta-analysis published by Carlos Zarate's group, which talks about the efficacy of racemic ketamine versus S-ketamine. And when they looked at the subgroup analyses, and remembering, of course, that they had to analyze each of these separately, so racemic versus S-ketamine, treatment-resistant versus non-treatment resistant, etc., it was interesting that the comparison of racemic ketamine and S-ketamine, although both were clearly better than placebo in their individual versus active versus placebo comparisons, but when you compare the relative risk of response and remission for racemic versus placebo and S-ketamine versus placebo, there was actually a significant difference favoring racemic ketamine. And likewise with the dropouts, that also favored the racemic group. Now, of course, there are no direct comparative studies of racemic ketamine and S-ketamine, and this could have been confounded by other factors. For example, that many of the studies of racemic ketamine are relatively small, unlike the studies of S-ketamine, particularly Spravato, which are quite large phase 3 studies. And some of these small, particularly early proof of concept studies would have been crossover studies of a single dose of ketamine versus a single dose often of saline, where you also wonder about blinding. And the authors did find that crossover studies tended to have a higher response and remission rate than the parallel group studies. So that could have biased these findings. It's why we think it would be very important to have large phase 3 studies examining racemic ketamine as a treatment for depression. And we've also conducted a meta-analysis in parallel with writing up the KADS study, which we will also be submitting. And with a systematic review, we could only identify 6 RCTs, which gave repeated doses of racemic ketamine in depression. And here are the 6 studies. You will see that the largest of these 6 studies had 81 people. Most of them were in treatment-resistant depression. 3 of the studies gave ketamine by the intravenous infusion method, 2 by oral, either a tablet or the oral solution, and 1, which was our own study, piloted intranasal ketamine. We stopped that study early after 5 people because we found that there were a lot of side effects. In terms of the comparator, only 2 used a comparator with active effects to improve blinding, and in both cases midazolam. And only 1 of these 6 studies actually assessed how effective the blinding was. And a number of studies examined follow-up. So the issues that we wanted to address in our study, we wanted to do a large phase 3 study of racemic ketamine. We, from our pilot studies, had decided that the subcutaneous route was quite practical and also relatively easy. So we wanted to use the subcutaneous route. We had also looked at using the intranasal route for racemic ketamine, but our pilot study found that there was quite a difficult technique. We learned really useful lessons about dosing from the KADS study, and we were also very keen to have a comprehensive assessment of safety, and not just acute safety the first 2 hours after treatment, but also looking at cumulative safety, assessing between sessions and also over the whole course of treatment. And the assessments that we developed were really a prototype of the ketamine side effect tool, which I'll talk about later. We were also very keen to do as much as possible to have good blinding. So we used different assessors for the mood outcomes and for safety outcomes, because if you've either seen any of the treatment session, or you've been involved in rating blood pressure or psychotomimetic side effects or any other effects, then you might have become unblinded. So we kept these people entirely separate. And we also formally assessed blinding separately for participants and raters, after the first treatment and at the end of the RCT. That's after 4 weeks, over which 8 treatments were given. So the study overall had 170 people. It was done over 7 sites, 6 in Australia, 1 in New Zealand. People with treatment-resistant depression, the usual definition of having failed 2 adequate trials of antidepressant medications, with a Montgomery-Åsberg depression rating scale score of at least 20. They were allowed to be on concurrent psychotropic medications if they had been stable for 4 weeks prior to entering the study and also during the study. It was a double-blind study, and the active control was midazolam. We gave it by subcutaneous injection starting at 0.5 milligrams per kilogram and 8 treatments over the 4 weeks. At the end of that time, we wanted to formally assess whether people would stay well over the next 4 weeks without any further treatment. They continued, of course, on any concurrent psychotropic medications which they were on. There was also a later open label phase, which I won't be presenting today. And apart from efficacy and safety, we also collected data to assess health economics. We collected blood to assess pharmacokinetics and pharmacodynamics, and blood biomarkers and genetic predictors. So here is a overview of the study design, and I'll just be talking about this first part, the RCT phase over the 4 weeks. People are assigned to ketamine or midazolam with an assessment at the end of the 4-week RCT phase and a further follow-up 4 weeks after the end of the RCT. The primary aim, of course, was to assess the effects of a 4-week course, and secondary aims also to look at other outcomes, which I've mentioned. The primary outcome was remission at the end of the 4 weeks RCT, and defined as a MADRS score of 10 or less. This was assessed about 3 to 4 days after the last treatment. Those of you who've worked with ketamine will know that the peak effects are often at 24 hours after a treatment, and I know that some of the other RCTs, for example, the pivotal studies of Spravato, assess the primary outcome the day after the last treatment. So in some ways, this is a bit of a tougher ask, that we assess the outcome 3 to 4 days after the last treatment. Now, the study plan was to give ketamine at 0.5 milligrams per kilogram or midazolam at 0.025 milligrams per kilogram. And it just worked out with the concentrations of both of these drugs, which were both clear solutions, that this dosing resulted in exactly the same volume of injection. A trial pharmacy prepared all the drugs, a kit for each participant, and the vials were identical in appearance. So the trial pharmacy, and there was an unblinded statistician, were the only 2 people who knew the randomization assignment. Everybody else was blinded in the study. Now, at a routine planned review of the Data Safety Monitoring Board, there was no actual analysis, but when they reviewed the data of the first 51 people who had completed the RCT phase, they noted that there were no remitters at all in the blinded data set, so either in the ketamine or midazolam groups. They wrote to the trial steering committee with advice that we should review the dosing protocol. So we actually halted the study for a few months and adjusted the dosing protocol. So for the second cohort, we actually had an escalating dose over the 8-week treatment period. So you can see here the 4 levels, starting at the same level as in the first cohort, but escalating to 0.6, 0.75, and 0.9 of ketamine, and with corresponding increases in midazolam. The doses were increased to the next level at treatments 2, 4, and 6 if there was less than 50% improvement from the baseline MADRS depression score at the rating done just prior to the treatment. So for example, if in session 1 you had this dose of ketamine, when you came for session 2, you had a MADRS rating before the treatment. If you had not improved by 50% from baseline, you would then go up to level 2. You would continue on that treatment. If you came back at session 4 and you still had not improved in your pre-treatment rating by 50% from baseline, you would go up to the next level, and so on. Now, in terms of safety assessment, we had already conducted a systematic review of safety. And one of the key findings was that many studies had assessed acute safety in the 2 hours after treatment, but there was much less data on longer-term safety. Since we published this systematic review, the Spravato studies have come out, which do report longer-term safety, but apart from that, there's hardly any data in the field. So we then developed the ketamine side effect tool, which was based on our experience from our pilot studies and also developing the assessment tools for the KADS study. And we also conducted then an international Delphi consensus with other experts around the world to come up with the ketamine side effect tool. And the ketamine side effect tool has several modules. There's an initial screening module to ask relevant questions in terms of the safety of receiving ketamine. There are corresponding baseline and follow-up modules, which can be done, for example, after 2 or 3 months of treatment. In the KADS study, we did it after the 4 weeks of treatment. And these assess things like liver function, bladder function, and cognitive function. So for the KADS study, we did liver function tests routinely at baseline and after the 4 weeks of RCT. And then at each individual session, there's a separate KSET module that, first of all, before you do any treatment, asks about any side effects that have emerged since the last treatment. So, for example, if people have had bladder effects that emerged the day after the last treatment, you actually want to know prior to going on with the next treatment. This module also assessed immediate effects for up to 4 hours after each treatment. And another very useful aspect was a discharge checklist. So this was very much based on, for example, an ECT type treatment service where before someone is sent out the door, you're checking a number of things, including their orientation, their blood pressure, etc. Now, I'll just increase the size of this so you can see. So here is cohort 1. We assessed about 450 people for eligibility, and 73 people were randomized in cohort 1. So you'll notice that the DSMB advice to us was after 51 people had completed the RCT, but some other people had already been enrolled in the meantime, although they had not yet completed the 4-week RCT at that time. So 73 people ended up being in cohort 1. You can see they were assigned roughly equally by random assignment to midazolam or ketamine, and most people received some allocated intervention, and that was the modified intent to treat sample. Very few people discontinued treatment. And here is the modified intention to treat sample, which included most of the people. And then again, we had quite good data at follow-up that most people were still in the study. To show you now similarly for cohort 2, again, we assessed about 500 people. We entered 108 people into cohort 2. We ended up closing recruitment in April 2020, which was also the time when COVID was really hitting the community. So we ended up only having 108 people who were equally assigned randomly to midazolam or ketamine. As you can see, there was only one person in each group who didn't receive at least one treatment. And very few who discontinued intervention. Now, this next part shows you at what level people ended up. So the final dose at the end of the RCT for most people, you can see was at dose level 4. For both the midazolam group, so that was 38, by far the vast majority ended up on dose level 4. And likewise in the ketamine group, again, most people ended up on the highest dose, although some people ended up on a lower dose, presumably because that's the dose at which they had achieved response. And the modified intention to treat analysis analyzed most people, so 53 out of the 54 randomized. Here are the sample characteristics separately for cohort 1 and cohort 2. You can see that the age was roughly in the mid-40s, the average age. Like many studies of ketamine, we found that males were predominant in the sample, which is quite an interesting phenomenon. People had been depressed for quite a long time. So as you can see here, about 6 years or so for the current episode. And they were treatment resistant. You can see here the median number of antidepressants failed. you see that the range starts at 0, and that's because a handful of people had a protocol waiver. These people were actually the most treatment-resistant people who had failed most antidepressants in prior episodes of depression. And so it seemed to be not very sensible to force them to demonstrate that they had, to go back onto antidepressants, which their own psychiatrist did not think were going to be beneficial, and to force them to have 2 adequate trials just in order to enter the study. So if on reviewing your records you had failed, and most of these people had failed about 10 or more antidepressants in prior episodes, we allowed them to go in without having demonstrated failure to an adequate trial in the current episode as an exception, but there were very few people who were in that category. I think it's notable that some of our sample had failed ECT. Many ketamine studies exclude people who failed ECT, and my own observations, both from research studies and also our compassionate use clinic subsequently, is that once you've failed ECT, you're really at a substantially higher level of treatment resistance, so it's much harder to get a response. So, for example, the Spravato pivotal trials excluded people who had failed ECT for the current episode, whereas you can see here that roughly about 20 to 25% of our sample had actually failed ECT in the current episode. And most people were on concurrent antidepressant medications. Now, in terms of the primary outcome, which was remission at the end of the RCT, you can see that in cohort 1, very few people remitted. Whereas in cohort 2, we had quite a big difference in the remission rates, about 20% in the ketamine group versus 2% in the midazolam group. And the statistics just here presented for cohort 2 are that the adjusted odds ratio of being a remitter, as you can see, are 12 and highly significant. Similarly, for response, very few responders in cohort 1, about a 30% response rate compared to 4% in midazolam in cohort 2, and again, highly significant. This graph shows you the change in MADRS scores from baseline over the 4 weeks of treatment, and each of these triangles indicates a treatment session. You can see with the ketamine group in red, the top graph is cohort 1, that although there was some improvement, it was not different from midazolam. And then over the 4 weeks follow-up, when there were no further treatments, people tended to return to baseline scores. In cohort 2, conversely, you can see that the groups separate and that the ketamine group continues to get better, remembering that for some people, there were further increments in dose up to treatment 6. Whereas the midazolam group had some improvement, but then didn't improve any further, and that difference was significant, as we've seen. For brevity, I've just summarized the safety outcomes in one slide. There were no serious adverse events in the RCT. The acute effects in the 2 hours afterwards were the typical expected type effects. The effects were more marked in cohort 2 than cohort 1, which you would expect because most of these effects are dose-related, and that applied to increases in blood pressure, the psychotomimetic effects, as well as physical effects, and these resolved by 2 hours. So there was no problematic side effect and none that required any intervention. There were no significant bladder or LFT changes over the 4 weeks. We also did a whole cognitive testing battery, and there was no evidence of any impairment. And that was done at baseline and at the end of the 4 weeks. Now, as I said to you, we did quite a detailed assessment of blinding. We asked after the first dose both raters and participants. That was 3 days later when they came for the next session, but before they had treatment. And we also asked at the end of the RCT separately, raters and participants. And participants were instructed not to tell the rater anything about their experiences during the treatment sessions. I've highlighted in yellow, I guess, the critical part of blinding that relates to the primary outcome, which is the rater-assessed MADRS score at the end of the RCT. Now, the Bang Blinding Index is quite a sophisticated analysis of blinding. It takes into account what treatment you had and also what you guessed and comes up with a score. A score of -1 is exactly the opposite blinding. That would mean that all people assigned midazolam guessed ketamine and vice versa. A score of 0 is perfect blinding. and a score of 1 would be complete unblinding. You can see here in bold the scores that turned out to be significant, which suggests that there was not a high degree of blinding. The scores are over 0.5. So you can see here that it occurred with midazolam in cohort 1 and also in cohort 2. For some reason, people were much better at guessing midazolam treatment than ketamine treatment. You can see here for ketamine treatment in cohort 1, there was good blinding, that there was no significantly correct guesses. In cohort 2 with ketamine, the participants tended to have more than chance guessing that they had received ketamine, but not the raters, either at the end of the first dose or at the end of the RCT. I haven't presented here the full statistics for simplicity, but that will be presented in our paper. So the raters were not significantly unblinded to whether people had received ketamine, although they tended to be unblinded to whether people had received midazolam. So in conclusion, we found that a 4-week course of subcutaneous racemic ketamine was both efficacious and safe in treatment-resistant depression, that adequate dosing is critical, as you could see in the clear difference in results between cohort 1 and cohort 2, and that the approach we used in cohort 2, where dose adjustment was individualized based on their response, we recommend as quite a useful and practical approach. We found that a subcutaneous method was relatively simple to use. It is a parenteral method, which has all the advantages of quite consistent drug delivery, as opposed to methods such as taking the drug orally, where the absorption is much more variable. But it was much more practical and simpler than an intravenous infusion. The decline in MADRS scores, or I should say the increase in MADRS scores over the 4-week follow-up period, suggests that ongoing treatment is needed to maintain mood improvement. And we've seen that, of course, in other studies in the field. We took every step we could think of to optimize blinding during this study. And you could see with our very detailed assessment of blinding that we don't think that blinding was completely achieved across all the treatment groups at both time points and for raters and participants. Although for the primary outcome, there was blinding to participants having received ketamine. And although the safety outcomes were excellent, we don't recommend that this means that there's no need to assess safety, but rather that there should be comprehensive assessment of safety, not just acutely during the sessions, but also between sessions and longer term. And of course, a large study like this has many people involved. Not all the names are listed here, but here are the trial sites and principal investigators, my study coordination team, who did an excellent job, statisticians. There are quite a large numbers of people on the trial steering group. I didn't have space to list them all. The George Institute, which provided clinical trials expertise, the health economic, and also the biomarker and pharmacokinetics team, the Data Safety Monitoring Board, and the study was funded by the Australian National Health and Medical Research Council. So I think we have time for questions.
Fantastic, thank you very much. Does anyone want to kick off with a question? Yes, thank you.
Hi, Colleen. Colleen, Jonathan this morning. I was just wondering about your thoughts on the need for the cohort to, changes in, to stratify or to do an adjustment of the dose in terms of how you understand that, vis-a-vis the, kind of standard understanding of the dose of IV. What do you think is going on there? Because you would think that it would suggest maybe maybe I'm not sure if some way in which the pharmacokinetics of the drug is affecting the outcome, because you expect the full dose of that drug to get into the circulation just as you would IV, just maybe actually with a similar profile. So I'm just wondering what you think about that doubling of the dose almost compared to the standard.
Okay, so I think there's two issues. I think you're asking not so much about the dose titration, which we had also studied in our pilot studies previously and found to be quite a good method, because our conclusion was that people seem to have individual differences in what dose they require for treatment response. And we found that for IV, IM, and subcutaneous. I think you're asking about why was it that most people ended up on 0.9 milligrams per kilogram, whereas a lot of the IV studies only use 0.5 milligrams per kilogram. And we actually had collected blood in our pilot studies. It took us quite a while to do the analyses. So after we had designed the study and embarked, we did find that the bioavailability of subcutaneous ketamine is about 0.66, which then fits with 0.9 of subcutaneous ketamine from a bioavailability point of view would be similar to about 0.6 of IV ketamine.
Got it. So there was a difference in bioavailability.
There is a difference in bioavailability with the different routes of administration. It's one of the complexities of the whole ketamine area.
Okay, we've got a few more questions. Got one here.
Just a short question. Thank you for your presentation. Julia Mobile from Sweden. How did you recruit patients? Was it through advertisement or referrals?
Did you hear the question?
Not quite.
How did you recruit your participants?
Yes. So look, we recruited very widely. Everyone was required to have their own treating doctor. We didn't just take people coming off the the streets wanting to come into the study, and we did that for safety reasons. And we also felt anyone who has a treatment-resistant depression really should be under the care of a treating doctor rather than just coming to the ketamine study. So people could inquire about the study, but their treating doctor needed to agree that it was reasonable for them to be in such a treatment. We did also have referrals from psychiatrists and general practitioners. So it was really all three routes of recruitment.
Great. Got one more question up here.
Hi, Colleen. It's Sanacora from Yale. Colleen, a quick question following up on Jonathan. Do you get Cmax levels? Do you have an idea where Cmax would be? The maximum concentration for this? And then the second part of that is, it looks like a very gradual response, but are you all of a sudden seeing people to start respond once they get up to the higher doses?
Yes. I didn't quite hear the first part of the question, but the second part, and when you look at the graph, you might think, oh, you just need to have multiple doses before you start to respond, but you're perfectly right. And remembering that we had the up titration at sessions 2, 4, and 6. If I were to do it again, I might have done it, more quickly, like at sessions 1, 2, 3, and 4, rather than 1, 2, 4, and 6. And the first part I didn't quite catch.
This is Cmax. Do you have any idea what the maximum concentration plasma was?
Yeah, so I don't have those results yet. As you can imagine, it's a huge exercise with, to have collected samples with, in many people. We collected blood at before the first treatment, 4 hours after the first treatment, and at the end of the RCT. They were allocated into multiple vials for collection of plasma, serum, and also for DNA and RNA analysis. But all of those analyses are being done.
Okay, we've got time for 2 more questions, so I'll just take one from the back there.
Hello, Colleen. This is Robert Schroevers from the Netherlands. Congratulations on a very thoughtfully carried out study. You mentioned the fact that patients who had previously had ECT without effect are less likely to have a clinical effect in your studies. Were you able to look at that? I know the numbers are relatively small, but did you get any impression of that? Because in our study, we also had a very treatment-resistant population. So I'm curious.
Look, I don't think we've looked at that, Robert. We did plan subgroup analyses, which I haven't shown here, but we were limited by the numbers in the cells. So the statistician only proceeded with that where there were sufficient numbers in the cells, and I don't think that was one of them.
I can imagine. Okay, thank you.
But certainly, I think all of us from our kind of clinical observations, including in the clinic, when people have actually felt, good, there's ECT and there's ECT, but when they felt good quality ECT, in my experience, your chances of responding to ketamine are substantially less. Or remitting, I should say.
So you've given more midazolam than anybody else, as far as I can see. Did you were you worried about tolerance? Obviously, people knew that they were getting the midazolam. What would your comment be about the idea of doing a long-term study where you potentially continue to use midazolam as a blinding agent?
Look, it's a very good question, and we were worried about midazolam just with sedation and also respiratory depression. So part of our safety screens was we did a screening questionnaire for sleep apnea, and they needed to have, and if anyone had a certain score on that, there was we used a pulse oximeter during all treatment sessions, which would obviously set off alarm if their oxygen levels dropped. We also had assessment of respiratory rate at all the time points that we did the other vital signs. So, and it turned out not to be a problem from that point of view. But I think you're also asking about, issues maybe even of dependence, having received 8 doses of subcutaneous midazolam. We did actually ask as well about, craving the study drug or seeking the study drug. At the end of the RCT, there were, from memory, something like about 3 people who reported they didn't use, but they were kind of wanting the study drug, although there was no evidence that this was an actual dependence, but probably more seeking relief from depression. And that occurred in both midazolam and ketamine groups. Well, there was only a small handful, I forget the exact number, something like 1 in one group and 2 in the other group.
Fantastic. Thank you very much, Colleen, for joining us.
Thank you.